Hello, everyone. My name is Ryan Dobbs, and this is my fall 2022 oral comprehension exam submission. This is for CSU Pueblo. That's Colorado State University Pueblo, graduate nursing. My project here today is focusing on reducing medication errors in a local facility. And I like to describe it as kind of like a two-pronged approach to how I plan on reducing this certain type of medication error that's actually kind of a critical one. So let's get started. So the story. About 2.5, 3 years ago, I got hired onto my unit as a brand new nurse, and it's a fairly difficult unit. It's a orthopedic trauma unit. And I had just gotten done with my preceptorship, and I had a patient who was on patient-controlled analgesia, PCA, and the patient was saying that they were at like 10 out of 10 pain. And this patient had, constitutional symptoms. This patient was weeping. I could see diaphoresis, that this patient was in a lot of pain. And so in my new nurse mind, I am thinking, okay, how am I going to manage this? And so I go through the patient's MAR, and I see that the patient has oral oxycodone that could be given. And so in my new nurse mind, I thought to myself, okay, what's the least lethal kind of thing here? Oral is always preferred over IV in the new nurse mind. And so that's what happened. I gave 5 milligrams of oral oxycodone while the patient was on patient-controlled analgesia, and I was promptly written up for it. I was written up for it because it is unsafe. Basically, you can't be giving an oral opiate on top of PCA because the oral opiate is going to raise their kind of like basal rate, right? It's almost going to be like a basal rate of opiate going through the patient's body, where the PCA is then spiking up and down on top of that. And one of these things that like really kind of messed me up here is I told this situation to one of my charge nurses, somebody that I greatly respect, and she told me straight up, she goes, yeah, that's one of those that every new nurse gets. And I was just like, okay, well, I'm going into grad school, this is something that I need to take care of, because if every new nurse is getting written up for this, there's obviously a deficiency or something going on here that needs to be addressed. Here's some logic that I had going into, after I had been written up, I was thinking to myself, why is this in the MAR? If the providers don't want me administering oral opiates while the patient is on PCA, why is it available? We are in a post-COVID time where nurses are being floated from every which way around the hospital. And this is something that if you hadn't heard like by word of mouth that you're not supposed to do this, then you would be set up for failure, basically. Why wasn't I taught this? Patients on PCA was kind of a rarity in my preceptorship, and so I never really got that much exposure to it. Why are there no additional instructions? What I'm getting at here is that for every medication in the MAR, the provider can put instructions on how they want it administered, right? Any provider could have simply thrown in there, please do not administer while patient is on PCA. Or if you would like it to be there for when you discontinue the PCA as a provider, then you can put on there to be given after the discontinuation of PCA. And so, where I kind of ended up with this was that providers are going to need something and nurses are going to need something, because I was deficient in this. I've asked around some of the charge nurses. They kind of think too that PCA we're a little deficient on. And then, there's something glaring here in regards to the prescribing of this from the provider, where the patient is on PCA and they have this oral opiate in there, and that is not okay. And that leads me to my next slide, where the Institute of Safe Medication Practices, or the ISMP as they are called, in 2003 they made a recommendation that no oral opiates should be given while a patient is on patient-controlled analgesia. And they have not revised that statement. That statement is still there, still true today, from 2003. And this is the problem, is that this is happening. This is happening fairly often. And remember when I told you in the beginning, this is something that every new nurse gets, okay? So this is a big problem. The ISMP also gives us guidelines. So not only do they say that oral opiates should not be prescribed with PCA, but they also make another recommendation. If you see at the top left, they also advise and recommend that a provider should have a hard stop or something to alert them that they are going against ISMP guidelines when they prescribe an oral opiate and PCA. Currently in my hospital, this is not happening, and this is a grave danger. Providers need to know when they are going against the recommendations of these overarching kind of regulatory bodies, right? And because that's not happening right now, they are still prescribing PCA while the patient has oral opiates in their chart. And so the first prong of my two-prong approach is going to be implementing that hard stop for providers when they try to prescribe oral opiates while the patient is on PCA. It's just not safe. And if they want to do so, then they should still be able to do this. The intent of this project is not to take that power away from providers. The intent of this project is to educate them right there in that moment that there is a guideline out there that says that this is not safe. The relevance to APR in practice, I think this kind of speaks for itself. This project is regarding the prescribing and the administration of opiates. Medication safety is one of the national safety goals that we currently have, okay? And this falls right in line with that. APRNs are going to have the power to prescribe opiates, and that is why this is relevant to their practice. The population affected is going to be the patients who are on PCA at or within the UC Health system here in Southern Colorado. These patients are at an increased risk by being on PCA, especially until we can kind of get this thing managed and get this hard stop implemented. The significance of the problem, this is fairly self-explanatory. Patients who are on PCA and are given oral opiates are at an increased risk for opioid toxicity, respiratory depression, and death. This is something that many of us know to be true. So, the current state of affairs. Currently, we are going against ISMP recommendations by not having anything alerting the providers that they may be prescribing against these recommendations. That is the first prong of this project, and I want to implement that hard stop. The second part of this project, after talking with some of the charge nurses, it seems that there is room for improvement amongst many of the floor nurses. And so what we have discussed is an online PCA refresher course that the nursing staff will complete every year with their online competencies. And this will just keep everybody up to date with what's going on with PCA in the hospital, especially in regards to the co-administration of oral opiates on top of PCA. All right, time to dive into some evidence-based practice. Okay, so my PICO question is In adult patients receiving PCA, does a hard stop alerting providers to the dangers of concurrent oral opiates as well as an education module for nursing staff regarding PCA and concurrent oral opiates, compared to no intervention, reduce the number of RL medication errors involving concurrent oral opiates while patient is on PCA throughout the duration of this project? I know that's a lot. Let me explain. The way I would like to evaluate this project is based on the number of non-punitive write-ups, which are called RLs in this case at this facility. By evaluating the number of non-punitive write-ups before these interventions have been implemented, and then comparing the amount of write-ups after these interventions have been implemented, I hope to see a reduction in those write-ups. That is kind of the focus of this project, is to reduce the number of write-ups and therefore medication errors that are going on within this hospital regarding this specific type of medication error. So, what does the evidence say? Initiating the hard stop. The hard stop stuff is severely lacking in evidence-based practice, kind of articles and stuff like that. And that, I hypothesize, is because most people are probably following this guideline to a T already. And therefore, there's not much research that needs to be done about it, okay? But, however, I was able to find some really good stuff about PCA education for nursing and clinical staff. So here is kind of like my literature review. As you can see, I picked 4 studies that met the inclusion criteria for my project. Let's see. For the initiation of the hard stop, I really don't need much evidence-based practice information because I already have the guideline. I have the guideline that says that that a hard stop needs to be implemented, and we are not doing that. I have already spoken with a PharmD at my facility, and she agrees that this hard stop needs to be implemented. Okay, so when it comes to the education of the nursing staff about PCA, I have 4 studies here. As you can see, none of them are systematic analysis, and none of them are double blind. I have a quantitative pre and post intervention cohort study. Actually, I have 3 of those, and then a retrospective cohort analysis. What you can garner from these 3 studies is that reinforcing PCA education can reduce PCA error rates. That's what you can glean from the top 3. The bottom one I threw in because it kind of incorporates health information technology. And as we, are coming up in medicine, technology is becoming more and more important. So in this study, they they computerize PCA adverse events, all right, and they monitored these and just kind of looked back and saw what was happening, all right. And I just really kind of enjoyed this because, technology is up and coming, and we really need to figure out how to use our technology the best to give our patients the best care possible. So one of these studies has, 2 of these actually have the nurses going to an in-service to have their re-education happening. I chose online specifically because of the ratios and the shortages that are occurring in our country right now. All right, evidence-based practice advocacy. So the governing bodies that are kind of intertwined in my project are the Colorado Board of Nursing, the United States Drug Enforcement Agency, and the Institution of Safe Medicine Practices. The theoretical framework that I am using is Kurt Lewin's change theory. It speaks to unfreezing, change, and refreezing. Basically, we've got to get out of our old way, okay? We need to make a change, which is the hard stop and the education. And then after everybody has learned and the hard stop has been implemented, this is called the refreezing phase, where everybody kind of gets on board with it and it becomes the new norm. So for leadership, I have already spoken with many fellows at my hospital regarding this project. I have a clinical nurse specialist on board, two PAs. I have 2 people on my team helping with literature review. And I also have the PharmD that I spoke of that is assisting me with just making sure that everything I'm talking about here is safe. We will be using the Iowa model to implement this project, and you can see the 8 components of the Iowa model here. ANA Code of Ethics. So, dilemmas. One dilemma I identified is that nurses are kind of hesitant to write themselves up, and we may not capture all of the medication errors due to this problem. It's kind of on the nurse to recognize, or the nurse's charge nurse to recognize when these medication errors are occurring, and not all the time. There's a possibility, okay, that not all the time they're going to be written up. Of course, always, one ethical concern is patient data. This project really is kind of devoid of patient data, okay? There is not much patient data here because I am strictly looking at the amount of RLs, which are non-punitive write-ups, before intervention and post. Cultural components. I really racked my brain for a lot of cultural components for this, and I really think that this is kind of just cut and dry objective quality improvement, and there really are no cultural components to this. Some more and more ANA Code of Ethics stuff, respect for human dignity. I believe this project respects human dignity by reducing the chances of a fatal overdose. This project aligns with the nature of health because I am trying to keep people in a therapeutic window with their pain controlled. Relationship with patients. There are some patients who may be upset about this and may be like, I take my oral oxys all the time. I don't understand why. I think that this program, this quality improvement project, is going to give people the tools to be able to tell them why it's not safe and why we're not doing it for them. Okay? Technology. The PCA machine itself, a lot of room for improvement, okay? The PCA machine could create a graph for providers to see kind of what's going on with the patient's amount of clicks and actual deliveries. If a chart could be made in the PCA machine showing how much use the patient has been getting from their PCA, that would be very beneficial. PCA machines are known to run away as well, which means that somebody will hit the button and it will deliver an incorrect dose. This can lead to problems. Okay? So after speaking with a lot of the providers, they would like 3 choices in the MAR for the oral opiate. Do not give while on PCA, call provider for administration, and okay to give while on PCA. Here are some more of the NOF, PF, and P competencies that I would like to speak to. Most specifically, this project aligns with national safety guidelines, the biggest one being medication safety. Here are my references, and here's my thank you page. Thank you all for listening to me. I thank you all so much, and I hope you all have a great day.